This is me. I'm Dr. Shantanu. I practice at a corporate hospital in Bangalore, run a DNB program there, and I'll be talking about nutritional deficiencies. Now, so it's an odd topic if you think about it, because most people who come in and have symptoms of dizziness, nausea, vomiting, food is probably not what you're going to be talking about. But at some point of time, when patients start getting better, attenders or patients at some point of time will ask, what can you eat? Well, is it really important? Is it something that makes sense to talk about? And that's something that we'll try to delve into. So the aim of our topic is not to talk about general web pages from Google which tell us that this is what you should eat, this is what you should not eat. It's not also going to be about things to avoid, such as migraine triggers, and if you're a known case of Meniere's disease, you're going to avoid salt and try to hydrate properly. These are not the basic sense of what we're going to be talking about. There are two ways that we can talk about nutritional deficiencies. One would be a very theoretical exam-based understanding of what happens when a particular nutrient is deficient. And that's not, again, our focus. Now, the tricky part is to talk about something as generally practical as nutrition to this audience who has been and probably will be treating a lot of patients with vertigo, and get an idea or an understanding about how can we make this practical. What exactly does it mean to talk about specific nutrients with the perspective of patients with peripheral vertigo? So we'll try to keep things somewhere in the middle, somewhere which is just a little bit theoretical, but just enough practical to make a difference in our daily treatment of such patients. So there are more than a few nutrients which we read about which have some role in patients with vertigo, so patients with dizziness, and that's where things get a little blurred. So first of all, we need to understand whether we are talking about patients with vestibular pathologies or patients with non-vestibular pathologies. Vitamin B6 and B12, this is something which has been littered on our prescription pads for a very, very long period of time. And is it really sensible to treat patients with vitamin B6 and B12? So we'll just run through a few basic heads under which we're going to be talking about some of our nutrients, some of these things. Vitamin B12, I mean, that's something that we read about in a lot of patient papers. And although it's an extremely important nutrient, it's something which is important for fatty acid metabolism. It's very, very important for preventing anemia because of normal blood function. And it's also important for formation of neurotransmitters such as serotonin, etc. And patients who do have nutritional deficiencies come with a myriad of symptoms. So you can have patients who come in with ataxia, with disorientation. Most chances are that these patients will come in and say, Doc, I feel dizzy. They may not necessarily say that I feel that everything is spinning. They don't say that they have on history a vestibular pathology. And that's because most of the times they don't. They usually have a combination of anemia, peripheral neuropathy, sometimes cognitive mood disorders, and therefore a lot of these symptoms are non-vestibular. It's easy to supplement this, especially if you're a non-vegetarian, so you can supplement it with various food sources, meat sources, animal sources. For vegetarians, you've got dietary supplements, which are dairy and products, soy products, whey proteins, etc. And it's important to think about these kind of nutrition supplements and maybe give that little piece of advice to your patient. B6 is often sometimes used at the same line as B12. That's because a lot of the biochemical functions are very similar. They do help in amino acid, fatty acid metabolism, in heme formation, but they also help in neoglucogenesis, and therefore patients with B6 deficiencies can get hypoglycemia. And a lot of these symptoms might suggest that the patient is dizzy. Again, the sources are a lot more, so there are many vegetarian sources, but when we are supplementing B6, it's really important to know that very high doses can cause neurotoxicity, And it's important to understand why we're treating them with B6 and B12 supplements. So the question is there a definite correlation when we're doing B12 and B6 serum levels? Because we often write that on a prescription paper that why don't you go and get these values done? There is a definite association of B6 and B12 deficiency with a lot of these symptoms. But at the same time, these aren't due to any vestibular pathology. There are more than a few studies which suggest that any form of vestibulopathy, whether it's Meniere's disease, whether it's BPPV, whether it's any vestibular neuronitis, have no real association with decreased serum values of B12 and B6. So although we know that we should look for these symptoms, but blindly starting a patient on B6 and B12 may not necessarily help. The only way that I would, in my mind, think that it might help is as a placebo, and a lot of times we may want to use it as a placebo, but that's pretty much it. There's no evidence-based medicine. Now, magnesium is something which we don't talk about a lot. Magnesium is something which does a lot of things at the intracellular level. We don't necessarily, when we are prescribing a vitamin B complex or a supplement, we don't always pay attention to whether magnesium is there in it or not. It has a lot of function, again, for various intracellular functions, for neurotransmission, for calcium metabolism, but again, doesn't have a very strong association in literature with vestibulopathies. So why am I really talking about this? And that's essentially because there is some association, a fairly significant one, with migraine. That's one thing which, where it has been associated. Now, as you can see, there are more than a few different names that has been utilized with the term vestibular migraine, and that's probably because it's probably been an area of debate. It's something which has not always been accepted, and more so in the ENT community. If you talk to a neurologist, which I often do in my hospital, they will very strongly suggest that this is probably the most common cause of peripheral vestibular symptoms. Not something that we all agree with, but over a period of time, there have been certain standards set down. There is a very distinct definition of what vestibular migraine is. There has been more debates, but at the same time, we have now been able to start identifying vestibular migraine patients. But the more the complex the patient, the more we find that people look for a little bit of flexibility. And that's why, thanks to newer and newer classifications, aside from having patients who are diagnosed as vestibular migraine, we have patients who are diagnosed as probable vestibular migraine, which pretty much means the same thing, but it allows us to start treating more and more patients in a similar fashion. Now, why we're talking about this is because a lot of patients with migraine have benefited with magnesium supplements, and the basis is the vascular effect that they have on vasodilatation and vasoconstriction. Magnesium supplements have been associated with improved migraine symptoms. Patients with vestibular blood flow decrease have been found to have vestibular migraine, and magnesium plays a long role in it. And there are more and more reports now in literature which suggest that supplementation with magnesium has not only improved migraine, but also specifically migraine-related issues of vertigo. So it has improved vestibular migraine. So should we be treating all patients with query vestibular migraine with magnesium supplements? Well, literature does tend to think so. It says that because magnesium is widely available, it's not very cheap. There is no toxicity really known with magnesium supplements. It might be a good idea to start using it. But the question, at least in this piece of literature, suggests that empiric treatment should be used. Now the question is, why should we not just do magnesium levels and then decide whom to give supplements and whom not to give supplements? The answer is very simple. We don't really detect magnesium very well in our bloodstream. It's something which is primarily intracellular or in the bones, and therefore less than 2% is actually in circulation. So whenever we do look for magnesium on blood and urine tests, it's not really significant. It doesn't tell us the situation. But then again, when you are anyway treating patients of vestibular migraine with your line of treatment, pharmacotherapeutically, might be a good idea to add dietary supplements, especially if you're not losing anything. So in my mind, if you have a specific patient with a clinically diagnosed case of vestibular migraine, once you've ruled out the pathology being in the vestibule per se, then it's a good idea to add supplements. Most of these supplements are easily available, and it's something I think we should start doing if we are giving any form of supplement. Now, on a more personal note, if you're from a city which has lack of good water supply, this is a common picture that you'll see. You see water tankers which are carrying around a lot of water which is from the underground table, deep underground table. A lot of times this is hard water, and hard water is distinctly known to have large amounts of magnesium in it. So chances are that we may see a few cases less than somebody who stays probably right by the water. The last nutrient that I'm going to talk about is probably the most important in today's day and age when we're talking to an ENT audience. Peripheral vertigo has more and more been associated with deficiency of vitamin D. It's been being researched for a long time now, but more and more over the last, say, 5 to 7 years, we're seeing a lot of papers which suggest an association with osteopenia and BPPV, with osteoporosis, with D3 levels being less. And there are quite a few studies which give a mild association, some of them conflicting, but some of the newer studies are suggesting that there is a distinct association. For example, this study which actually says that by supplementing with vitamin D3, they found that there was a distinct decrease in the incidence of BPPV. This another study over here. I'm sorry, I don't think it gives the topic head here. Okay, but it even suggests that patients who have had recurrent BPPV, making sure that you're supplementing and carrying out studies to find out whether the D3 levels have gone up, have decreased the recurrence rate in recurrent BPPV. So especially for patients who've come back to you more than once with similar symptoms, like was suggested by Dr. Suratwal in one of his earlier talks, it might be a good idea to start these patients on supplements. Now, one of the ways that we assess calcium metabolism is doing bone mineral densitometry, and that's an easy way of assessing. It's not. Okay. Okay, so this essentially says the same. Yeah. Okay. Yeah. But bone mineral densitometry does not show a distinct association with recurrence rates. It still is found to be affected if you start doing a cross-sectional study in patients with the BPPV, but recurrent patients do not necessarily have a fall in the bone mineral densitometry. That's what this says. So essentially, what this is suggesting is that you should tell people to get out a little more, and whenever in doubt, you should supply vitamin D supplements. Now, if you're looking at long-term vitamin D supplementation, you can give shorter, smaller doses in oral form between 400 to 1,000 units, international units per day. Or when you're looking at acute episodes and you're really thinking that the patient requires an acute improvement in the vitamin D, you can give it IV as well. So essentially what we understand is that diet is important. So the take-home message here, well, it's not exactly this. But essentially what we need to understand is there are more than a few things which we should pay attention to while talking or counseling the patient. And one of them, in a patient of BPPV or a patient of peripheral vertigo, should be diet. So bottom line is B6 and B12 are not associated with any vestibular pathology. You can supplement it for other reasons, especially if you're suspecting dizziness of a non-vestibular pathology, especially if it is vascular in nature, and definitely in anemic patients. Magnesium supplements is fairly helpful, especially in vestibular migraine. Serum vitamin D is one test that is going to be helpful in the long run, and it's something that we should be doing in patients with BPPV, especially if we feel the symptoms are significant, especially if the patient has recurrent symptoms, especially if you're running out of options and vestibular rehabilitation doesn't seem to be helping. Find out whether the patient has significantly decreased levels of vitamin D and supplement it, because it's easy to supplement, it's easily available, and I think that's the way forward. Thank you. Happy to answer any questions if anyone has.
Yeah. Dr. Alfargal may ask on B1. Yeah.
Thanks for this very interesting presentation. I just wanted to share with you that we studied the vitamin D serum levels in almost 500 patients of BPV. And we found that this is still not published, but we found that in more than 93 or 94% of them, they have a very low vitamin D levels.
Correct.
And in our practice, it's become standard in our institute just to screen for vitamin D serum level. And once we got a diagnosis of BPV, and we immediately start the supplements. One more point regarding the vitamin D is that there is a strong evidence that it decreases the risk of falls in elderly people. There is many studies that prove that vitamin D supplementation improves the risk of falls in elderly. So I fully agree with you. Practically, vitamin D should be incorporated in the care of the dizzy patient. Just one more thing, that is, recently we published this article on case report for bilateral vestibulopathy, acute bilateral vestibulopathy in vernix encephalopathy case because of the malnutrition. Vernix encephalopathy is a neurological disorder. It's very common in alcoholics, but also it can occur due to nutritional deficiencies where vitamin B1 or thiamine is deficient and causes many CNS symptoms, including cerebellar and vestibular symptoms. And we have suspected this case because it presented with bilateral loss of the horizontal canal, VOR gain. And we checked the thiamine level, and it was very low. And we started the supplements, and within 2 weeks we could restore all the function of the patient and patient norm to his normal condition. Thank you.